Hello everyone, and welcome to the first AMCHP Global Health webinar of 2024. Thank you everyone for joining us, and we're going to go ahead and jump in. To start off, I just want to introduce the AMCHP Global Health webinar to those of you who may not be familiar with it. So we are a group of MCH professionals, students, academics, and learners who are interested in global health and how we can learn from the experiences of what others around the world are doing to better inform our work in the US. And so our vision statement, which is on the slide, is that AMCHP's Global Evidence-Based Practice Initiative, which is our work group, seeks to identify and share culturally appropriate best practices, bright spots, and insights from the global community with Title V and its partners. We aim to value and uplift community expertise and cultural diversity in public health, as well as create space for collaborative transnational learning in maternal and child health. It's kind of a quick primer on kind of who we are and why we're here, but I'm going to go ahead and this is just our overall agenda. Going to do intros and get some learning objectives established before Dr. Agarwal and Mariana are going to do their presentations, and then we'll do a structured and unstructured Q&A, and then a quick wrap up at the end. And if, in terms of questions, if people could please hold them until the end, you can always put them in the chat or in like the Q&A box, but the questions overall are going to be for the Q&A period of the webinar. So our learning objectives today are to increase participant awareness and knowledge of the current digital and technological innovations being applied in the MCH field and their impact, to encourage participants to think creatively and collaboratively about the potential applications of digital technology in contributing to improving the health of MCH populations, and to demonstrate the potential impact of digital innovation in global health to inform and support domestic Title V work. And now we're going to introduce our panelists. So starting off, we have Smisha Agarwal. Dr. Agarwal is the director of the Center for Global Digital Health Innovation and an associate professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Dr. Agarwal studies how to improve maternal and newborn health in low-income settings through strengthening community health systems and leveraging innovative technological solutions, including digital devices. Over the last decade, she has supported the development of programs that employ digital tools, such as mobile phones, to improve healthcare services for women and children. This has included the development of point-of-care clinical decision supports, tools used by community health workers and other healthcare providers, and patient-focused SMS-based health behavior change interventions and conversational agents, like chatbots, that use natural language processing to communicate with users. She's also developed methods for evaluating such digital programs and led a series of systematic Cochrane reviews on the effectiveness of digital clinical decision support tools and longitudinal health records that have been leveraged by the WHO to develop global guidelines on the use of digital tools to strengthen health services. And then our second panelist, Mariana. Anna is a member of our Global Health Workgroup, and Anna is a founder and CEO of the Indonesian Global Health Foundation. She is also now working as a lecturer of global health in the Division of Community Medicine at the Universitas Jenderal Achmad Yani in Indonesia. As global health practitioner and medical doctor, Anna is passionate about improving healthcare delivery, management, research, and innovation in Indonesia. She has over 8 years of experience in various sectors, including academia, private and public sectors, where she has contributed to enhancing patient care standards, operational procedures, and telemedicine implementation. She also graduated with a master's degree in global health delivery from Harvard Medical School. She has developed skills in contact tracing, public health, maternal health, and she's received certifications and awards for her inspiring work. She has experience designing and implementing public health interventions, conducting research, evaluating programs, and she built the Indonesian Global Health Foundation to support and ensure healthcare services are available for all, especially those who need it most. So now that we've learned a little bit more about our panelists, I'm going to stop sharing my screen and pass it to Dr. Agarwal to share her slides.
Great. Hi, welcome everyone. Okay, great. So I think I was asked to speak specifically to how digital tools can be applied to maternal and child health. Um, and I think we're doing 15 minutes of talking through, you see my slide, yeah?
Yes, we can see your slide.
Like a time. Okay, perfect. We'll have maybe 15 minutes and I can go over some of these slides and happy to take questions afterwards. So I brought in sort of a variety of what is digital health, how do we think about it in reproductive health, and some sort of more traditional programs, as well as, since there's a growing interest in AI, some sort of emerging ways of applying digital health approaches to maternal and child health. So first, some framing of how do we think about digital applications in healthcare, and I think these the context of my work is mostly in low resource settings. So in the US, when we think about digital health, we very quickly think about electronic health records and Epic and EMRs. In a lot of other settings, especially where health services are a little bit more limited, digitization really emerged as a catalytic approach where mobile phones were available even where electricity or water was not available, right? And so the early questions that emerged were, how can we use mobile phones to actually strengthen the delivery of health services? And so it is really thought about more comprehensively, more than just apps or electronic medical records. And so this is one way to think about it. This is the Tanahashi model for health systems. It talks about how, if we want to achieve population level health outcomes, we first need to understand who the total population is, the target population. How can we get adequate coverage of health interventions? How can we address some of the supply side barriers, some of the demand side barriers, and then quality and cost of healthcare services? And we know that when we are delivering each of these, or when we are addressing each of these areas, determinant layers of universal health coverage, we keep falling short, right? We may not know who our population is. In a lot of countries where we work, there is no enumeration or social security equivalent of the population. We may not, if the populations may not have access to basic commodities like drugs or human resources like doctors or nurses, midwives, or have concrete ways to access health facilities. And then even if there is supply, the demand may not exist for services for a variety of reasons. And so this is where on the right-hand side, you see some strategies that might help address the gaps to provide sort of that addition that can help circumvent some of the systemic issues in the delivery of health services. And so registering clients digitally is one way. When clients have a digital record, let's say a newborn baby is born and they have a digital record, we're able to then quickly refer them to immunization services. If a health facility has a digital record, then they're able to note that the baby did show up for immunization services. And so by sort of that digital connectivity, we can improve the continuity of care and address each of these layers, determinant layers of UHC. And so that's one way to think about digitization. There are a variety of sort of strategies that can be used. We go here from client registration, and it's an example that I used, but there is, we can provide training to providers, telemedicine, which is a popular one, especially in the context of COVID-19. There might be behavior change communication strategies where through text messaging or the use of apps, we can engage potential end users or individuals, let's say pregnant mothers, pregnant women, and then decision support to improve quality of care with providers. And on top, you see mobile financial transactions to improve accountability of services. Here's another way to sort of think about how digital strategies are being used across the continuity of maternal and child health care. So here are some sort of conventional strategies for community-based care, where we mobilize communities, support birth preparedness, counsel and prepare individuals for newborn care in the prenatal and antenatal care period. We facilitate clean delivery, and then we facilitate sort of early recognition of care seeking for illness in the postnatal care period. And digitization can help across each of these stages of maternal health care by providing patient education, delivering health content via SMS or voice follow-up calls, audio, video, training clips. Noting that, traditionally some of this outreach was done, let's say, through radio services, which may or may not reach everyone, and it's also not individualized. But with sort of digitization, where a mobile phone, a number can be individualized to a person. So let's say if a woman is in her third trimester, she can very much receive messaging that's appropriate to her pregnancy stage, for example, and help with, say, birth preparedness, or help with an understanding of what to expect in the intrapartum and postpartum period. Some more approaches for outreach services here include decision support tools to monitor and record blood pressure, weight gain, risk factors for complications. And so this gets into the space of remote diagnostics. And then you see sort of here, there is an EHR mention, but you see that EHR is really a small piece of the broader puzzle, and digital health is fairly sort of all-encompassing area where, I think there was a recent World Bank report that talked about the idea of digital in health. And we see that in countries that have sort of more advanced healthcare systems, where digital is so critical to a healthcare system that you don't notice it. It's just how you deliver health services. And so here, finally, in clinical care, we see early detection and referral for complications. And I'll go through some examples of what this might look like, where digitization can be used for emergency referral services, care coordination of mothers and newborns across formal and informal sectors. So I'm looking at the time, but I have a few case studies I can talk to you about, and Ollie, feel free to stop me when I've hit time, and I think I can just pause at the second case study and we can keep talking. But the first one is sort of a more traditional, using routine health services, or here, let me actually go into an evaluation that we conducted in Burkina Faso for a clinical decision support tool that was being scaled up by the ministry in collaboration with Therese Deon, TDH, to improve quality of prenatal care and IMCI, integrated management of childhood illnesses, so care of sick children. And so to give you a bit of background, Burkina Faso is a landlocked country with a very high total fertility rate and a high maternal mortality rate, fairly good coverage of prenatal care services, but we don't have an understanding of the quality of those services. What we do know is that within the country, there's low outreach and adoption of national health guidelines around pregnancy care and care of babies. There is inadequate implementation of reproductive health standards and protocols by healthcare workers. And then there's poor quality supportive supervision for the healthcare workers, which means there isn't an oversight on quality of care services delivered. And so a few partners led by the Ministry of Health in Burkina, they implemented the ADA approach. It's called the IEDA approach, which involved the creation of an electronic register for consultations. And it was launched in 2014, with the maternity care module being launched in 2019, which is what our team at Hopkins was focused in on evaluating. So there are two components of this electronic register. There is REC IMCI focused on children, and then REC maternity focused on mothers. And so, like I said, there are a number of stakeholders. It was led by the ministry and TDH, and we were the evaluation partner along with ISSV in Burkina. The main objective of the program was to support reduction in maternal and newborn mortality by increasing midwives and nurses' adherence to reproductive, maternal, and newborn health protocols, and improve quality of care by improving decision support and case management. And specifically, the goal was that if we digitize women and newborn health protocols and provide case management support to healthcare workers, we can improve quality of care. So it included checklists, algorithms that guide healthcare workers in the delivery of care. Strengthen primary healthcare services through improved perinatal care services by building capacity of healthcare professionals, promote the use of data to be responsive to the needs of the population. And a little bit more about where the intervention was delivered. We were able to conduct a quasi-randomized study across the country with certain intervention and comparison areas. Here is the algorithm and what it covered. But essentially, when a woman came into care, a healthcare worker was able to use a tablet-based clinical decision support tool that helped enter information on where the woman was in their care journey, or where the child was based on their primary symptoms. And based on the data, the algorithm asked a series of questions that the healthcare worker could then systematically follow. So the intention there was that if we are following an algorithm, that we are asking all the questions that are needed to make an informed diagnosis, and that we are following the recommended protocols for informed treatment and referral services. And I'm not going to go into the details of our results, but they are available, they're published and available here for those who might be interested in reading them. Since there is interest in sort of the use of AI, and I mentioned how digitization can be used to identify sort of high risk cases, we were able to analyze over close to 170,000 sexual and reproductive health service encounters to understand what are some of the trends in service utilization of women, and what might be. And we actually didn't have enough clinical data to get to we started off thinking, can we create risk models for preterm birth, or can we create risk models for any sort of adverse outcomes, but there wasn't enough granularity of clinical data to do that. But what we were able to do is work very closely with the Ministry of Health to really think about how to improve the quality of the data instead of focusing on outcomes. Okay, so moving on to the next case study, it's really thinking about, and this is a primary area of work for me, is how can we think about harnessing this online space for delivery of care services, especially in sexual and reproductive health. There is a lot of stigma associated with the types of questions that individuals need to ask to feel empowered. And so what we know is that 4 in 10 people use social media, internet. I like this little model here that says, I'll let you know that I Googled my symptoms and I'm now pregnant. But the truth is that a lot of individuals, even those in low literacy or low resource settings, can spend, maybe 30 seconds or 4 minutes with a doctor and then 4 weeks online Googling what's wrong with them. And it really creates a lot of room for misinformation, disinformation to thrive, and for individuals to be misinformed and not have quality access to health information. And so we've been exploring a number of online digital avenues for engaging populations in safe conversations that really empower the end user. And noting here that online forums are a safe space in accessing sensitive health information, but they also hold a lot of risks. As we all know, it is a huge topic of conversation. There's misinformation, there is risk to confidentiality, privacy, there's lack of validated information by medical experts, but there are lots of benefits as well. And so maybe I see I'm running at the end of my time, so instead of walking through the slides, I'll just talk through some approaches that we've considered, right? Like, first of all, there is a lot of content online, and we've tried to use it to understand what is it that people are talking about in the online space. right? So what are the top 10 reproductive health conversations, and how can we use an understanding of what audience needs are, of what client or patient needs are, to actually create content, create health content that effectively engages them? Because often people don't really want to know about what the healthcare system wants to tell them about, right? They want to know about sort of things that are of interest to them. So you see, these are some of the questions that our team these are some of the questions that our team analyzed based on 120 million comments on Reddit, and the types of questions that individuals were asking each other about. And this was done pre-ChatGPT, but we can do a very similar approach now using ChatGPT and minimizing our 6 months of work into 6 seconds by simply asking ChatGPT. But so that's, I think, an interesting approach that I encourage everybody to become familiar with, because it can save you a lot of research time. So that's one approach. And then once we've understood what individuals online are seeking, how can we address those concerns? And that's where we've explored a number of different modalities, a chatbot being one of them, where how can we integrate with, in this case, with Facebook to actually engage individuals, triage them, or either refer them to a telemedicine service or home-based care, and then or engage with them in an educational and counseling approach, where it is really led by the user, because we can use natural language processing and we don't have to, guide them through an algorithm. We can very much be responsive to user needs. So maybe I'll wrap up there and turn over to Ana Maria, and I'm happy to discuss any of this further later.
Thank you so much. Yeah, go ahead, and we'll go ahead and pass it to you on Mariana to go ahead and share herself.
Okay, thank you so much. Okay, thank you so much for this opportunity. I would like to present about the telemedicine's contact doctor implementations for high-risk pregnant women in rural maternal care in Garut District, Indonesia. So as we know that Indonesia is the third largest country in Asia and the fourth largest globally, with around 255 million inhabitants. And also based on the data World Bank, Gini coefficient Indonesia in 2019 is 38.2, and the poverty headcount ratio at the national poverty lines is 9.4% of populations in 2019. And the problem of maternal mortality in Indonesia is still high, which is, we can see that among with the other countries in Southeast Asia, maternal mortality in Indonesia is still remain high, which was 177 maternal mortality per 100,000 live births in 2017. And this is the Garut District, West Java Province. When I were doing the implementations of Kota Dokter, so Garut is a rural district located in the southwest of the West Java Province in Indonesia. And this locations is one of the district which was the highest contributor to the maternal mortality rate in West Java Province. And maternal mortality rate case in Garut was 184.5 per 100,000 in 2013. So I would like to explain just briefly about what I'm doing in Indonesian's Global Health Foundations. So I built my own NGO, Indonesian's Global Health Foundations, and or Yayasan Global Set Indonesia. And we built to improve health equity, especially in limited resource setting or rural areas in Indonesia. And we focus on addressing the problem of health inequity in Indonesia by providing donations for those who need it the most, doing health promotions, building health and social initiatives, and gathering voices from the field related to global health challenge and initiative in Indonesia. And our focus are in the maternal and newborn and child health, strengthening primary health care, and also health promotions and health educations. These are our visions and our missions, doing the donations, health and social project, health promotions, and also implementing digital health solutions. Our values, impactful, equity, integrity, and respects health as human right. So why focus on maternal and newborn and child health? As I mentioned before, that maternal mortality remains high in Indonesia. Also with the national neonatal mortality still remain high, and there is critical needs in child health and nutrition as well. So our solutions, the telemedicine services, we call it the Kotak Dokter Telemedicine Services. With our initiative, we believe that distance is no longer an issue. We provide a telemedicine device for pregnant women who live in a rural area by connecting them with doctors, midwives, and nurses through online communications. Our telemedicine services could improve rural maternal care by allowing pregnant women to connect with healthcare providers effectively. We also succeed in partnering with various stakeholders, local governments, local communities in rural areas of Indonesia. So our solutions have 4 values: health promotions. Improving health promotions and awareness during pregnancy is a critical need. Innovation tools, integrated telemedicines, and also improve health outcomes. So this is our video.
Ini tuh salah satunya membantu untuk meyakinkan pasien bahwa kadang ada pasien yang seharusnya dirujuk tetapi tidak mau, ada yang tidak seharusnya dirujuk tapi dia tetap pengen dirujuk. Padahal pasien tersebut mempunyai diagnosa yang bisa ditangani oleh dokter umum sendiri.
Sebuah inovasi yang sangat bagus, bisa menghemat waktu, menghemat uang, juga bagi pasien membantu ketepatan diagnosa. Dan yang paling penting dari semuanya adalah kepuasan pasien, karena pasien merasa satu, dia bisa menghemat waktu, tidak perlu berlelah-lelah, subuh-subuh ke rumah sakit, dan dia puas karena untuk kasusnya dia ditangani oleh dokter spesialis. Bagi kami itu sangat-sangat penting kepuasan pasien.
So this is the implementations of Kotak Dokter specifically for the telemedicines telemedicines for primary care and also for the improving maternal health outcomes. And our impact has been reached 2 regencies, 3 sub-districts, more than 20 villages, and more than 355 online locations. And this is our board. So during my master's degree, I did the thesis or research specifically to evaluate the implementations of Kotak Dokter for high-risk pregnant women in rural maternal care in Indonesia. So the background is that we understand that the inequality has been identified as a significant obstacle to maternal health. And as we know that the problem of MMR in Indonesia still remain high, And the WHO has highlighted the importance of telehealth for essential maternal and newborn health services during the pandemic. Hence, the particular interventions need to be implemented primarily in rural areas to promote the early detections of high-risk pregnancies. And my research questions, I would like to understand about the patient's experiences and challenges to gaining access to rural maternal health care services, particularly for women with identified high-risk pregnancies. And the second is to understand the patients and healthcare provider satisfactions and acceptability. And third is to identify barriers and facilitators of telemedicine contact doctor implementations. And I did the convergence mixed method study, and the locations of the research was located in the rural area in the Garut district, and the implementation timeline during July and also during July to September 2022. And the result of social demographic, we found that the level of educations commonly for the high-risk pregnant woman was the high school, and the main occupations of the patients was the housewife. And the family income is less than 1 million rupiah per month, or less than $66 per month. And this is the social demographic of healthcare providers. And for the first research questions, I would like to understand what are the problems and challenges in accessing and providing maternal care for high-risk pregnant women in rural Indonesia. And I found that for most of the high-risk pregnant women in my research, that they usually receive the healthcare from Puskesmas and also from Posyandu. And they said that they don't have any difficulty with transport to the rural maternal care. And between 5 to 10 minutes, or even between 10 to 20 minutes, they get to the rural maternal care from their houses. And this is the conceptual framework of problem in accessing and providing maternal care in rural Garut, Indonesia. From the individual aspect, we found that there was a lack of socioeconomic patients, pregnant women preference based on their cultures and beliefs. From the family aspect, there was long distance marriage, delaying making decisions from family members. From the healthcare facility aspect, there was difficulties in accessing maternal care. And from the health system aspect, there was the discriminations of patients in health insurance. These are details in the challenge in individual aspect. There was lack of socioeconomic status and long distance marriage, difficulties in accessing maternal care, and there was discriminations of patients in health insurance. And these are the challenge and the problem that facing from the high-risk pregnant woman in rural maternal care. And the second questions I would like to understand about what is the patients and healthcare provider satisfactions and acceptability with implementations telemedicine of contact doctor. So from this study, I found that from both patients and also healthcare providers, they said they were satisfied and acceptable for these contact doctor implementations. And we use the modified telehealth usability questionnaires from the usefulness, easy of use, learnability, interactions, quality scales, satisfactions, and future of scales, reliability, and also from the safety. And from the doctor's perspective on using contact doctors in each of patients' consultations, we found that from doctor's perspective, there was a change in clinical care or management after doing online consultations using contact doctor for these particular patients. And doctors said that the interactions quality of using contact doctor was quite good and also very good. And the last research questions I would like to understand is that what are the benefits, barriers, and facilitators in implementing the telemedicine of contact doctor? From the benefits, time and cost efficiency, help improve patients' health outcomes, help reduce the workload of healthcare providers in Puskesmas, help improve the skills of healthcare providers, and help identify actual conditions in the field. So from the barriers not familiar with the technology, struggling to fit with doctors' schedules, bad or slow internet connections, limited physical examinations, communications online versus offline, and the imbalance between the large workload of programs and limited human resources at the puskesmas or community health centers. And for the facilitators of Kotak Tutor implementations, in line with the visions and missions of puskesmas, and Kotak Tutor provided a secure privacy, and also the Kotak Tutor was convenient and easy to use. And these are the collective of the barriers and facilitators of Kotak Tutor implementations. So this is the discussions for the challenge in accessing and providing maternal care for high-risk pregnant women, the lack of socioeconomic status, difficulties in accessing maternal care, and there was limited access to maternal care during pandemic COVID-19. And there was a strong belief in using traditional birth attendance for a pregnancy checkup. And there was a long distance relationship that leads to delays in making decisions by family members. And also there was a discrimination of patients in healthcare insurance that influence access to care. These are the benefits such as saving costs, distance and times, and there was the high level of patient satisfactions, and the barrier such as the poor internet connectivity is such a major obstacle. So the limitations of this study is this study was limited because it was only specific to the high-risk pregnant woman and conducted in one community health center or puskesmas. Hence, it will influence the generalizability. And also additional limitations of the study include bias in patient selections and response bias of those completing this, the survey. And a future study of evaluating implementations Kotak Dokter should involve a large sample size of different participants, a group of health workers, and also all pregnant women. So the conclusions from this study was the implementations of this telemedicine Kotak Dokter gave a lot of benefits for pregnant women, especially for high-risk pregnant women who live in rural areas. However, there are some challenges of its implementations. Puskesmas doctors said that there had been a change in clinical care or management after doing each online consultations for the woman with high-risk pregnancies. Both high-risk pregnant women and healthcare providers gave a positive response, also satisfied with the implementations telemedicine of Kotak Dokter. And several barriers of implementations telemedicine of Kotak Dokter we found in the study were divided into barriers from patients, barriers from healthcare providers, and also barriers from technology and health system. So our recommendations was enhance capacity of puskesmas to be ready to implement telemedicine program, provide comprehensive training of digital skills to all healthcare providers in puskesmas and caterers in the village. Third is the collaborations between private sectors and also the governments need to be reaffirmed so the telemedicine system can be implemented to improve access to maternal care, especially in rural Indonesia. The last government needs to initiate and preparing the regulations on decisions regarding insurance coverage and reimbursements for implementations and sustainability of telemedicine services in primary care. So thank you so much.
Thank you so much, Anna Mariana. It was really great to hear about both of y'all's different kind of different work and different kind of approaches to looking at technology in the MCH field. So we're going to go ahead and move into a kind of structured Q&A. So I'm just going to go ahead and share my slides again. And so our first kind of structured question that we have is for both of you is what are some key insights that you've gleaned from your experience in the digital MCH field? I know this is a pretty wide question, but kind of anything is helpful. And whoever wants to go first, I don't know.
Go on, Anna Mariana.
Okay, so for me, okay. So thank you very much for these questions. I think for my perspective, what I've learned from the field is that the implementations, specifically implementations of the telemedicine in rural area, it should be initiated by the governments. So the way we work is that we were doing the B2G, business to governments. So the community health centers or puskesmas try to collaborate with us, and so these implementations of Kotak Dokter can be accessed free by doctors and also by the healthcare providers and also by all the patients in the rural areas. So I think the collaborations between the private sectors, the government sectors, and also all the stakeholders, specifically for the local authorities, community health workers, needs to be really involved for the implementations of the telemedicine, specifically in the rural area.
Yeah, and maybe I would just add, there are multiple ways to address this, but to Anna Mariana's point of rural areas and addressing populations in rural areas, one of the limitations of digitization can be who is accessing services, especially for maternal health. There are gender dimensions. In a lot of cultures, men are the ones who hold any sort of phones or access to devices. Also, while there is actually in most countries fairly good sort of coverage of connectivity, it is not complete, and so digitization is often a great first step forward. It is not sort of it is not often the way to get to the last mile or the last 1%. And so thinking about great, let's digitize, but let's digitize where appropriate, where it makes sense, where there is adequate network connectivity, where we can think very holistically about who we are reaching, who we are not reaching, and how can we still capture the people that we're not reaching.
Thank you so much. That's really helpful, and that makes a lot of sense. And so our next question is, I know you, there we go. I know, Anna Mariana, you talked about collaboration between the private and like the kind of public sector and government. But if you could speak a little bit more about kind of who have been key collaborators that you've worked with to deliver your projects. We focus so much on like community engagement and ensuring that people with lived experience, I think especially on the kind of Title V and domestic side of things, that people with lived experience are involved. So so we're just wondering if you could speak a little bit more about your kind of community collaborators or any kind of key collaborators that you've had.
Okay, so yeah, so in my case, we are from the private sectors, from the NGO. We collaborate to build the health project initiative with the governments, especially in the West Java province, from the Jabar Digital Services and also the Discom Info. So we got the grant to do the pilot projects to implement these telemedicine services in the several areas in 2 regency and more than 20 villages. So we trying to rent our telemedicine services specifically to be implemented in the community health centers in the puskesmas for 1 year. And we were doing the evaluations and for the first implementations of Kotak Dokter in the rural area, especially in the community health center or in the puskesmas, we were doing the training, and we educate the community health workers. We educate the healthcare providers who are gonna using this Kotak Dokter And then so that's kind of the collaborations that we have done so far. And for now, we are trying to do another pilot projects, but also we are trying to collaborate with another local authorities or governments in any other area. So yeah, we are trying to collaborate with more stakeholders, not only specifically to the governments, but also with the local authorities, with the healthcare providers, and also with any NGO.
Great, and I think not that different from Mariana. Working with the end users is always critical. It's surprisingly not often done, right? Like where end users are often missed. People are coming into the space with an idea for a fun new technology, and the images, if you build it, they'll come. But I think especially in clinical settings, often digitization might disrupt or interrupt clinical workflow. And so really, I think collaborating with the end users, whether they are clinicians or patients or people in between. And then as we're thinking about scaling up, collaboration with any health officials who are part of the chain, whether if you're in a private sector, then a private hospital system, or if you're in the public sector, then the district and national level sort of ministry representatives.
Excellent. Thank you so much. So we're going to move on to our kind of unstructured question. We have one in the kind of Q&A and then one in the chat. So we're just kind of going to go in time order. But we have one in the Q&A that is specifically for Ana Mariana. It says, on your slide on the conceptual framework problem in accessing and providing maternal care in Indonesia, can you provide additional details on the health system? So discrimination of patients and health insurance. Can you describe the health insurance in Indonesia? Government insurance, other free access to care. So just a kind of maybe just a high level overview of what the kind of payment structure and insurance structure looks like in Indonesia.
Yeah, so talking about the government insurance, especially for the BPJS, we called it the BPJS in Indonesia. It was quite challenging and also the complicated, because when I did the study specifically for the pregnant woman who also got the and doing they are part and a member of the healthcare insurance, they said to me that there was some of the discriminations, especially for those who are the member of the government insurance or the BPJS insurance compared to the private insurance. So that's a huge issue in Indonesia. That's the reality, especially that there was some of the level in the BPJS or the government insurance. There was the level 1, there was the level 2, and there was the level 3, and yeah. I think this issue that's quite challenging and really complicated in Indonesia. So I hope that in the future, the government, especially for the Ministry of Health, can really make sure that there was no discriminations for all the members, specifically for all the patients who are part of the members of the BPJS insurance, because we try to make sure that we can provide healthcare for all without any discriminations. So yeah, talking about the government insurance or BPJS insurance, and also relations with the telemedicines, honestly, there was no specific covered for the telemedicine implementations in the BPJS insurance or the government's insurance in Indonesia. Yeah.
Thank you so much. Yeah, hopefully that was that kind of got at the brunt of the question. I know I found that very illuminating. I'm not overly familiar with the health insurance system in Indonesia, so that was very helpful. And then we have one more question in the chat. And as the panelists mentioned, access to phones, good internet coverage, maybe some peculiar challenges faced by rural dwellers. Are there other digital approaches that can be utilized in these resource-limited settings to increase access to maternal child health services?
Yeah, I mentioned that there are specific challenges for rural populations, and there are lots of potential solutions, right? But the solutions have to be considered. So a way to access, to be able to continue charging devices, to access 3G connectivity. There are sort of devices or strategies that can be used to facilitate it, but they should be considered, and they can't be considered if we are not upfront recognizing that not everybody can access services, right? And so, I would also say that often coverage is better than what we might think it is. And so, there is increasingly data available for what coverage of services looks like. There are, so if you go back to some of the my first two slides, there are a host of modalities, right, that are listed. Digital is not one thing. It is, you know, hundreds of possible interventions that I could not possibly list here. And so, so there are a host of modalities that can be used to engage populations based on what the barriers are to reaching them. There are, you know, I guess I think of them maybe in three sort of buckets. One is direct to consumer services, right, where you're accessing and reaching out to mothers, caregivers of children directly. It might be through mobile-based services, let's say, and I think those are often trickier because you're depending on individual connectivity, which tends to be quite variable. Then there are services that are delivered by healthcare providers within health facilities or through outreach services like community health workers, or in primary healthcare services like Puskesmas in Indonesia, for example. And connectivity at that level is usually better than the connectivity of individuals. And so that's another. And then there are health systems-based interventions that really look at streamlining some of the systemic challenges, let's say supply chain or management of human resources or payment of human resources to improve accountability of services.
Thank you. And then Ana Mariana, did you want to add anything, or?
Yeah, I completely agree with the Dr. Smisha said earlier that for the implementations of digital health, we cannot only specific to one aspect, because there were some other aspects that needs to be considered about how to really make sure that these implementations, the digital health implementations, can really be implemented specifically in the rural areas, and consider that there were some of the limitations for its implementations, and also some of the barriers. So I think consider that one of the facilitators that needs to be considered, so the telemedicine services programs can really be implemented in the community health centers or in the Puskesmas. There was in line with the visions and also with the missions of the Puskesmas, and this digital health implementations could be improve the healthcare outcomes, and can really follow up the health outcomes of the patients, especially for the patients who need it the most. So yeah.
Excellent. Yeah, thank you for that insight. I do see there's another question in the chat, but we are coming up on time. So unfortunately, I think we're going to, yeah, Dr. Agarwal has to hop off, of course. Yeah, thank you so much for your attendance. With our panelists permission, I will grab their slides and their contact information and send that out to all the participants who registered. And the recording itself will be posted on AMCHP's website in the coming days. Thank you so much for attending. We really, really appreciate it. I know I've learned a lot. This has been such a fruitful conversation, and I think there's a lot of kind of different considerations and applications that we can consider, especially in rural settings in the US and domestically. So, but like I said, thank you so much. We're right at time. And if you have any other questions, please feel free to email me. My email is okuo, which is okuo @amchip.org, or you can email evidence@amchip.org for more information or to get in contact with me. But like I said, thank you so much, and have a great rest of your day, everyone.